move to the next talk, Dr. Rajesh Sinha, who's going to be talking about preoperative and intraoperative measures to prevent endophthalmitis. We can continue the discussion after this. Yes. Thank you, sir. Like always, it was a wonderful talk, which actually is the complete thing in itself, and it is, yeah. It doesn't need any more talk. It doesn't. So Rajesh is going to be talking about preoperative and intraoperative measures to prevent endophthalmitis.
Thank you, ma'am. And just going to the last point once again, maybe prednisolone phosphate will not cause deposits in place of acetate, so we can use prednisolone phosphate. Coming to the preoperative and intraoperative measures to prevent endophthalmitis, there are certain preoperative measures which are there in the guidelines, and we have to keep all these things in mind. One is a good control of blood sugar, because a diabetic individual is more prone to develop endophthalmitis, and somebody who is having an uncontrolled diabetes, the risk of developing endophthalmitis is higher, because the patient is bound to develop some reaction, and then that can get subsequently infected, and if the blood sugar level is uncontrolled, then if there is an endoph, the severity will be much higher. Then of course we have to look at the NLD block, press the sac, do syringing if possible, but don't do anything on the day of surgery, like don't do any syringing, don't do any biometry or tonometry on the day of surgery. It has to be done before that, and see if there is any infection in the lid and adnexa. In that case, that has to be managed first, treated with antibiotics, and once the congestion resolves, the best thing is if there is a congestion in the eye, you think there's an infection in the ocular adnexa, the best thing is to send a swab, and then start treatment with broad spectrum antibiotics, and then of course you get to know how the patient is resolving, and then plan the surgery at a later date. Preoperative topical antibiotics, most of us give, and there was a recommendation earlier that it has to be given, but these days it has not been considered as a mandatory thing, but most of us we do give, because we want to play safe, we want to reduce the normal bacterial load on the ocular surface. But what is mandatory is use of povidone iodine 5% in the eye. And I would just like to emphasize 5%. Why? Because normally 10% betadine is available, and you have to dilute it by 50%. That is important for the use on the ocular surface. 10% is good for the skin, periocular skin. There's no need for clipping the lashes. As you can see here, the drape has nicely covered the lashes, and these days we don't clip the lashes. As far as intraoperative measures is concerned, the adequate OT sterilization is important. Then the common method of sterilization these days that we use is use of bacillocid. We do spray of bacillocid 2%, and then keep the room closed for 5-6 hours, and then that suffices. UV radiation is also useful, but it has to be stopped at least 2-3 hours before somebody enters the operation theatre. Periodic cultures to be taken every 1 to 3 months' time. You can take moist swabs taken from microscope and head end of the table. You can keep blood agar plates open for 30 minutes at the head end of the table, and that is how you get to know whether there's any significant infection or not. Of course, colony count of more than 10 is significant, and any even a single gram-negative bacillus or a fungal colony is something which is suspicious, and we have to go ahead and do something for the OT sterilization. Then sterilization of instruments is very essential, and that's again a big topic to discuss. But yes, we preferably use ETO or autoclave or plasma. That is better, but there are other methods as well to sterilize the instruments, and that can be done. The best thing is, ideal thing is the use of disposable instruments mostly. And if you use disposable items largely, then the risk of infection will be less. And of course, we use chemical indicators to look for the monitoring of sterilization of these instruments. And the general guideline is this, that if you are introducing any instrument in the eye, then it should not be reused in the other patient without sterilization. So it has to be sterilized. Adequate hand washing is important. If you are using betadine or chlorhexidine scrub, then it should be done for 3 minutes. If you are using any liquid soap, it should be done for 5 minutes, and bar soaps should be preferably avoidable. And the important do's and don'ts should be there on the wall of the scrubbing area or area adjacent to the main operation theater, so that people follow that. And proper gowning and gloving is essential. Somebody who is using a gown and has gone out, then in that case, the surgeon has to come back and remove his gown, wash it, scrub again, and these things should be followed. Mask should properly cover nose and mouth, and OT cap should cover all the hair. The position of hand after you have scrubbed, it should be above the waist, and we should document every event that has happened in the surgery in order to have a nice post-op monitoring. Patient should also be cleaned. The eye, the periocular area should be cleaned. So the skin around the eye should be cleaned with betadine 10%. And if you are putting inside the eye, you have to dilute, as I said earlier. So as I said, for cul-de-sac, conjunctival sac, we have to use 5% povidone iodine, and outside skin we should use 10% povidone iodine. Povidone iodine is mostly available, as to my information, in 10% solution. So if you are putting inside the eye, in that case you have to dilute it, because otherwise it will cause some toxicity to the ocular surface. So 5% povidone iodine inside the eye and leave for 1 minute, and that suffices the sterilization of that area. And then as far as irrigating bottle is concerned, a large majority of our cluster end-off, they happen because of the irrigating fluid. So we should inspect the irrigating fluid, whether there's any suspended material in that. And of course, once you have used the irrigating fluid, we should keep some sample of it, so that we get to know, in case the patient develops end-off, then we get to know the culture of, by doing culture of the fluid, we get to know the organism, and that is also very useful. Intracameral antibiotic is very useful and has been considered, has been recommended by large majority of studies done outside, studies done in India, and they have all recommended that intracameral moxifloxacin can be used. The simple method of doing what I follow is that after doing the surgery, once the lens is in the bag, you hydrate the wound, ensure that sometimes you have to tuck the IOL optic to put it in the bag. So hydrate it, form the chamber, and once it has been done, then after hydrating the side port, you just see that it's reasonably tight. Then you inject intracameral moxifloxacin, and just you enter the side port and push from there. So it will, as you enter, there will be slight egress of fluid. So there will be space created, and you just push the moxifloxacin. It will go directly and towards the bag. Don't take your cannula too much inside to put moxifloxacin in the bag. Then the chamber will become very shallow. Again, you'll have to hydrate. We'll have to form the chamber, and then the concentration of the moxifloxacin will reduce. There are many studies that have shown a good outcome of use of intracameral moxifloxacin. And of course, wound security is another important thing to prevent endophthalmitis. If you feel that the wound is leaky, you should try to hydrate the wound. If you are in doubt, then you can put an air bubble, hydrate the wound, and if the bubble becomes smaller, this means that it has become watertight. There's no leak of water, because if there's any leakage of water, the bubble will increase in size. And if at all there is a doubt, one should not hesitate in putting a suture. So in conclusion, endophthalmitis, yes, it is on decline because of so many reasons, because of awareness, because of involvement of the ophthalmologists aggressively in this area. And we should take appropriate preoperative and intraoperative measures, and adequate sterilization of the instruments, the OT, and intracameral antibiotics are helpful, Well, not mandatory, I would say, because large majority of doctors, they don't inject intracameral, but it is recommended. It has been recommended in most of the studies, and as far as you'll be safer if you have given and documented, so that because in case of litigation, you will be a little safer. You can say that you have followed everything. Otherwise, these days, these advocates, the lawyers, they Google everything and get to know that, okay, you have not injected this drug intracamerally. But the most important thing, once again I will emphasize, is the role of 5% povidone iodine in the cul-de-sac. Keep it for 1 minute just before the surgery and then wash it off. And that prevents the risk of endophthalmitis in large majority of cases. So thank you very much for your patient listening.
Thank you, sir. Thank you, Rajesh. I think it was a wonderful talk, more so because it was on prophylaxis and you covered everything really very well. Yes?
Yep. Sir, do you suggest any additional precautions to be taken of sterilization of the instruments that we use for HVSAG and HIV cases that we do in cataracts, other than the disposable?
Yeah. See, for HIV and all these HSV and HCV cases, what we follow is that we do it as the last case, wherein we take all the precautions, everything, the surgeon's precaution has to be taken in terms of mask, in terms of covering the eye, etc., as well as the nice cap and separate gown. So all the surgeon's precaution is taken, and as far as patient precaution is concerned, it's the same as in any other case. So the only thing is that most of the times when you do the surgery, after that you have to close the OT because you don't do any other case after that. So
Yes, so the instruments what we are using for the cases, can it be gone to the routine sterilization? And what we generally do is we are separating the instrument sets of HVSAG and HIV as two different sets, and we use only those sets for the positive cases.
Absolutely, that is the way, and plus obviously it has to be separated because it shouldn't be mixed with other instruments, and proper thorough washing, I guess a bit more aggressive cleaning is done before it is put into the sterilization.
According to the books and protocols, we see that hypo is used for prior wash of that instruments. Because of that, our instruments are becoming a bit more blunt, and our quality of HVSAG and HIV cases output is coming down. So is it okay if we do only the regular sterilization what we do with the other instruments, or do we really need that additional dipping of the instruments, additional half an hour more in the hypo and then going it for the sterilization?
See, isopropyl alcohol has been found to be useful, but the only thing is that there is precipitation, and for sharp instrument it is not very useful. So as far as sterilization is concerned, if we have a good quality sterilizer like plasma or autoclave, I think that should suffice. Only thing is that these instruments should be kept separately. As far as possible, try to use disposable instruments, and the remaining instruments which are not disposable, these should be kept separately. Thorough cleaning should be done separately, not along with other instruments, and then it can be sterilized in autoclave.